Hi guys. It's a little bit bright in here, so I'm not gonna look like I'm really on the screen. Woo! So hopefully, um, we'll just be able to get through all these discussions and I'll have a better background next time. So we're gonna share my screen here. We'll talk about 14, 15, and 16 today. Mm, Unfix this here. Hang on. Okay, there we go. All right. Trying to get this off the screen. So from the beginning, chapter 14, anxiety and anxiety disorders. Um, there's a lot of different anxiety disorders that are out there. And we talked about a few in class when I was explaining the rationale. So we'll go over them a little more depth here. So anxiety, as is mentioned in class, is not the same as fear. Anxiety is just a vague feeling of unease. Fear has an identifiable stimulus. So anxiety does not. Um, the anxiety disorders we're going to talk about, they share some things that are behavioral, emotional, cognitive, and physiological. If you guys remember Hans Selye from Psych, he's the one who said that you adapt or die, basically. And adapting is another word for coping, and it's related to the amount of stress that you carry in your life and your ability to cope with the stress. Any effective coping with stresses in your life, which is the wear and tear on the body, will manifest as anxiety. Okay. Like I just said that. Levels of anxiety. We have mild, moderate, severe, and panic. Um, Mild is a good one. That's where you kind of want to be when you're taking a test. You know, there's something that's different that requires focused attention. You have increased sensory stimulation. You're very motivational. It's very motivational for you. Moderate, that's where you start having some of the difficulty with concentration, more nervousness and agitation, but not as bad as severe. Severe is where you see the somatic changes, the increased vital signs, the restless, the anger, tightening muscles. You actually see, because the muscles are tightening, you see a higher pitch to the voice when someone's talking to you. They have a higher tone, higher pitch when they're in severe anxiety. And then panic is complete fight or flight, fight, flight, or freeze response. You have the complete, you know, dilated pupils, slow digestion, all that norepinephrine stuff. So when we're dealing as nurses with anxious patients, we have to be aware of our own anxiety and maintain our calm so that we can keep our patient calm. Um, Very simple, easy to use sentences. Try to ratchet that person down from moderate to mild or from severe to moderate. You get to panic, there's not much you can do. A very low, calm, soothing voice, and always safety is a concern. So remember that one. So the following statement, true or false? Anxiety and fear are considered to be two different things. Yes, they are two different things. Some of the anxiety disorders that are out there, agoraphobia, which is a phobia related to wide open spaces or being outside amongst people. Panic disorder, which is different than panic on the spectrum of anxiety. Panic disorder comes like 100%, 60 miles an hour right out of nowhere. Um, Specific phobias, I know we all have a different thing that we're probably uneasy about, but these are true phobias. Social anxiety disorder or social phobia. This is also known as a avoidant personality disorder, which we'll talk about later. And then generalized anxiety disorder is kind of the catch-all for all that. Anxiety, highest prevalence of all mental disorders. More men or more women than men. It's variable depending on what's going on in your stressors in your life and how you cope with them. So other disorders related to that, selective mutism. Someone just doesn't talk because of their anxiety. Medication-induced anxiety. Some people get this way when they use inhalers and they don't feel like they can breathe. Select anxiety disorders due to another mental condition. Depression is one of the best friends with anxiety. So you see that combination a lot. And then in children and animals and things like that, we see separation anxiety. It's very common. I'm a neurobiological gal, so I believe in all the theories that deal with GABA and serotonin. But there are genetic theories regarding anxiety. Is it a fight or is it a something you learn how to cope from your parents, or did you inherit it from your parents? I don't know. Freud talked about defense mechanisms as psychoanalytic. Interpersonal with Pavlov talked about anxiety and being something that people are repressing and they need to talk about. And then behavioral therapy is learned behavior. Again, I don't know. Are you born with the neurotransmitters, or you're not born with them, or you're born with receptor sites, you're not born with them? I don't know. Culturally, we do have to deal with anxiety. Some cultures do such suppression that they'll actually have physical complaints, headaches, backaches, stomach problems, pain. Those could be somatoform, which is another anxiety-induced disorder, but we're gonna talk about that special all by itself later on. So don't worry about that right now. Some cultures think anxiety symptoms are because of their spirits around, but you just have to remember to be culturally sensitive to the differences that are out there. Combination medications and therapy is always best for anxiety. We can use some antidepressants because, like I said, antidepressants are the best friends with as best friends with anxiety. So you're going to see some benzodiazepines, you're going to see some non-benzodiazepines, you're going to see some SSRIs. If I want you to know which one, I think we had on our test today, or the little quiz thing that we did today, we had an alazapram and diphenhydramine. So probably a good idea to look those up and look at the interaction between the two. And then, of course, my favorite, cognitive behavioral therapy, where we change the way somebody thinks, turning negative into positive. We can also do decatastrophizing. So what's the worst thing that can happen kind of situation? And then assertiveness training, which starts with I feel, I think, I believe, but usually I feel. So the following true or false? A neurotransmitter dopamine is associated with anxiety. Well, no, it's GABA and serotonin. Age, conditions in children, they manifest anxiety through that selective mutism. So you have a kid who's just not talking because they're so anxious. You see it in the movie sometimes. Oh, he saw his parents shot and now he's not going to talk. That kind of thing. Separation anxiety, we've talked about before. And then social anxiety disorder. Some kids just do not enjoy being around big groups of people, and that's okay. Later in life, we see more phobias and generalized anxiety. Panic attacks become less. We see a lot of rumination. Later in life, rumination means they're trying to determine if their life was worth it, and they tend to dwell over the bad things, which we need to guide people towards more determining that their life was worth it. And that's pretty much ego integrity versus despair at the end of life, developmental crisis. And then the SSRIs, we've talked about a few of those that would fall in this for treatment of anxiety. Possibly, I wouldn't go with anything like Prozac, but Paxil is really good for social anxiety. That's just the big one. Pamelor, some people use that. That's a really old one. Um, but neither one, I don't think you want to use either one of those on the final. Oh, as far as anxiety goes. But I'll tell you about that when we get there. So, anxiety is a warning that you're not dealing with stress, you're not coping effectively. So, we need to understand that to manage stress, you got to be healthy. To be healthy, you have to manage stress. So, you have to learn how to deal with it. We can't get rid of it. It's not going to go away, but we do need to know how to deal with it. And sometimes if you need medication, it can be a PRN. Um, Positive attitude helps, belief in yourself, assertive communication, expression of your feelings. A lot of patients don't want to talk about their feelings. Um, but that's our job, is to help them talk about their feelings. Help people learn to relax, set realistic goals, diet and exercise, limit the caffeine and alcohol, and stress management. Now, panic disorder, this is not the one that I'm talking about on the spectrum. This is a completely different disorder. Um, you can have, they're discrete. They happen just right away. It's diagnosed when recurrent unexpected attacks follow by at least 1 month of concern or worry about future attacks. And half the people with panic disorder also have agoraphobia. Just some statistics. They have an increased risk of suicidality and avoidant behavior. I don't want to talk about too much primary and secondary gains with panic disorder because it'll only confuse you when we get to somatoform. So just don't even think about that, okay? The treatments for panic disorder, cognitive behavioral therapy, deep breathing, relaxations, and then of course our medications. I mentioned before the benzodiazepines, some SSRIs, tricyclics, and then some antihypertensives work for panic disorder like clonidine or propranolol. A lot of time I think that these used in ADHD in children also help with childhood anxiety and panic disorder potential. Okay, so there is a rating scale for anxiety called the Hamilton Scale, and you can look at that in your book if you want to. When we're doing an assessment, we want to look at their general appearance and their motor behavior because a lot of people with anxiety have automatisms being self-soothing or stress-relieving anxiety. This is the person who maybe has an ink pen, and they tend to, you know, it's automatic for them just to chew on their ink pen, or you hear this, or they use their hands and just, that's an automatism. So it's just something that they do to relieve their own stress. We want to look at their mood and their affect. These people tend to depersonalize or derealize, which we talked about in previous chapter. And then we want to look at their thought processes. The more anxiety they have, up to moderate, can manifest in some disorganized thoughts, but it's really truly panic disorder when they lose all sorts of rational thinking in addition to disorganized thoughts. We want to look at their sensorium. Are they confused? Are they disoriented? Most time, yes. Their judgment's going to be poor. They may, because of that rumination, they blame themselves for things. They do not want to be around people, and they sleep a lot to avoid that situation. So, outcome identification, safety. I know we talked about this in class. Just remember safety is right up there. Therapeutic communication, help them manage their lower level anxiety, and lots of education. It's very important. So, which would you find in the following to an assessment with panic disorder? You should know this one. It is that automatism. Phobias are a type of anxiety disorder. They're persistent, illogical. Their response is completely out of proportion to the situation. Like, I used to have an extreme fear of heights, got stuck on the top of a mini Ferris wheel, had a complete meltdown. So something I could have climbed down. It wasn't that big of a Ferris wheel, but the response I had was just illogical. There are agoraphobia, which is this open spaces and being around other people, specific phobias like my fear of heights, social anxiety, or generalized phobias. So the specific phobias are natural or environmental. So heights, blood. Some people really have a thing for injection shots. Situational. Animals. Some people are terrified of spiders, terrified. And then there's other types too. I'm sure you guys can think. Somebody I had in a class before was had a phobia related to those like honeycomb looking things. They had the holes in them. And that has a name, but I don't recall what it is. I thought that was an unusual phobia. So for treatment, we're going to do the behavioral therapy with positive reframing, cognitive assertiveness training. We can do the systematic desensitization and the flooding if you want it faster. Again, fear factor, that show I was talking about in class. I still remember that one guy they made him put his hand inside this pot with a bunch of spiders, a tarantulas. Oh, so yeah, that's flooding. That it works faster than traditional systematic desensitization, but I don't know that I could do it. So the following statement, true or false? Phobias come from a past negative experience. I believe that's probably false because they come out of nowhere. Yeah. You just need to be aware of your own anxiety, your own phobias. You can't fix other people if you don't know who and what you are. And use techniques yourself to manage your stress and anxiety in your personal life because being a nurse is stressful. Being in charge is way stressful. So you need to figure out a way that you can keep yourself under control. All right, that's 14. Let's close this and the show. I'm going to stop my share. I'm going to go back and see if I can get 15 up. Okay. Okay, back to Zoom, and I'm going to share our screen again. Chapter 15, OCD and or obsessive compulsive and related disorders. There's related disorders in there too. Okay, slideshow from the beginning. So we have OCD. You should know what OCD is. It's a type of anxiety disorder. We have obsessions, which are recurrent and intrusive thoughts, and then compulsions, which are ritualistic behaviors that help us neutralize our anxiety related to the obsession. Okay. Some common types of rituals, the touching, the rubbing, the tapping. Some people might have to touch a wall every time they go past like a certain part in the wall, a different color, they might have to touch it. Checking rituals, that is where we were talking about in class. You go back and you check and make sure you turn the burner off several different times. Some people actually have a count to it. They must go back and check 4 times before they can go anywhere. They have to turn the doorknob 3 or 4 times as the counting rituals. The washing rituals were talked about in class. They might have to wash their hands, or some people pray. They have praying rituals where they have to pray, you know, but not only before every meal, but before every time they get in the car, or before every time they walk down to the basement. It just depends on the person. Ordering, ranging and rearranging. Some people have that type of a ritual because they don't ever feel like they can get it right. It's not perfect. And that causes anxiety, and then having a very rigid performance. Sometimes that is an OCD. Um, there's only one way to skin a cat, and that's not true. We know as nurses, there's multiple ways to get to the same situation. We just have to, in the beginning, follow the cookbook of skills so that we learn the skill and then we can create beyond learning the skill. OCD is diagnosed once the thoughts and behaviors consume the person, where anything else is not functioning the way it should. Person realizes that they're unreasonable thoughts and the rituals are unreasonable. They know that. They know they don't need to wash their hands 15 times. Their hands will bleed if they wash them 15 times, but they can't stop themselves. Well, they could stop themselves, but it would increase their anxiety to horrific levels. So they don't. It can happen younger and younger, but usually you're going to see it in the late teens or late 20s. And sometimes people can get by with less rituals, but that's not common. We spoke about these in class, the self-soothing behaviors. These are not reward-seeking behaviors, but self-soothing. Some people will pick at their skin. That makes them feel less stressful. Pulling out the hair takes away stress and anxiety, or nail biting. So animal might be nail biters. That's probably one of the more common ones. Compulsive BDD or body dysmorphic disorder. That's where they'll have surgery after surgery to make sure each side is even. Hoarding is a OCD. Those shows that show the people getting rid of things, that anxiety has to be astronomical for them. And then we spoke about kleptomania, which is the reward seeking, and the on the mania, which is buying. I always tell people, um, I'm a compulsive buyer. I do retail therapy, but I'm not as bad as you would see with someone with OCD. And then body identity integrity disorder. We'll speak about this one later on when we talk about anorexia and bulimia. Oh, okay. So the etiology, Beck says that people in childhood kind of are very anxious and they do things to relieve their anxiety. Some people, that they learn. Some people believe that it's something to do with your neurotransmitters. So nature versus nurture. Culturally, we have to look at the culture, and I'm Catholic, so we all feel guilty about something. That's just part of it. Um, some people with OCD believe in supernatural causes for different cultures. And pharmacologically, I think any disease is going to be different, but culturally, we need to respect folk remedies and herbal preparations, things like that. So is the following statement true or false? OCD can be manifested through many behaviors, all of which are repetitive and meaningless. That's a tough one. But it is true. Treatment usually is SSRIs, fluoxetine or sertraline, that's Zoloft and Taxol. Second line could be an SNRI, venlafaxine, or Effexor. And if they're really treatment resistant, we can use one of these and then add like apiprazole. That's a nice one, or risperidone. Those are antipsychotics. Response behavioral therapy, exposure therapy, and response prevention. So delaying doing the ritual. So they like to open the door or turn the knob 3 times before they walk out the door. Maybe they just walk out the door and then turn around and turn the knob 3 times. That's delaying it by a few seconds, but it's still delaying. So they can tolerate their anxiety. Assessment, there is a screening tool. You can look in that box at that screening tool for OCD. We want to look at their history, how they look. Sometimes, a lot of times, they're anxious. You might see it in a constant state of mild anxiety to moderate with the overwhelming anxiety. Their thoughts are usually obsessions coming out of nowhere, and there's something bad going to happen if they don't perform the ritual. Judgment, they know that what they're doing is irrational. They know it, but they just can't help themselves. They have to do it. They feel powerless because of the anxiety. The rules in relationships are very strained, usually, and then sleeping problems, weight changes with medication, their appetite, maybe do some odd things depending on if whatever the ritual is. Um, some problems, that we can talk about with panic, or not panic, but OCD, anxiety, obviously, ineffective coping, fatigue, low self-esteem, and skin breakdown, especially if they're hand washers. We want them to be able to talk about what they're feeling. If they can express their anxiety, they can decrease the amount of stress it puts on their body and the need to complete the rituals. So relaxation techniques, lots of education, the routines, so we can contract with them and have them cut back. Instead of washing their hands 10 times, maybe they do it 9, maybe they do it 8. That's a systematic desensitization again. Teaching Clammy about OCD and then how they need to talk, because if they don't, they're just holding their anxiety in. Teach them to maintain their medications, to learn how to tolerate anxiety as best they can. For families, it's hard. Families want them just to stop doing what they're doing. So you have to teach the family to be tolerant. They're not going to fix the person. Just monitor it, because the more rituals they do, the more anxiety they have. So which treatment option is appropriate for a client experiencing OCD? Exposure therapy. That's when they deliberately confront the situation that they're trying to avoid. The actual term is also aversion therapy. The following statement, true or false? The best way to help a client with OCD is to avoid talking about it. Well, heck no, it's got to be false, because they need to talk about it. And then you got to be aware of that this is a chronic condition. They understand that it's silly that they need to perform these rituals. They understand it. And when you assess them, you assess their anxiety level related to the ritual. And if you see more rituals happening in a day, their anxiety is going up. So you'll want to ask them about that more often. That's OCD. Very interesting concept. I think I've only seen roughly maybe 1 or 2 people with true OCD over time. It's very, very difficult to eradicate. Okay, so we're going to stop sharing. We're going to go back to get 16 up. Modules. 16, which is schizophrenia. And come back here and share my screen. 16 and share. I hope I'm doing this right, guys. I really do. I'm sorry if I'm not. Okay. I'm gonna move this thing out of the way again. Slideshow. And slideshow from the beginning. Okay. Here we go. Schizophrenia. It's a big one. It's pretty rare, actually. About 1% of the population experiences schizophrenia. I see maybe a little bit more of it. It is disordered, bizarre thoughts and perceptions. There are positive and negative symptoms. Positive symptoms are things that you can add, that are added to the person. So you normally don't have delusions and hallucinations. So those are added to somebody. So that's a positive symptom. And then negative symptoms are things that are usually taken away. So they lose their ability to make a decision. They lose their attention. They lose their normal affect. Those are negative symptoms of schizophrenia. Usually diagnosed late adolescence, early adulthood in the 20s. Until just 1% of the population. We do have things called schizoaffective disorder, which is basically schizophrenia plus a mood disorder. They're very sick. Abrupt or insidious. So the clinical course, when we first find someone with schizophrenia, it is usually because they've had a psychotic break. So you may not notice it. They may be talking in the corner to somebody who is not there, and you think, okay, you're listening to music or whatever in their earbuds, but really they're having a slow psychotic break. Immediate course, well, they're not going to get any better. So this is a meds for life kind of thing. So we want to control the positive and negative symptoms. They're going to have remission. So they're going to come back and be pretty cognizant and then relapse, depending on when the medication needs to be altered or changed. So long term, the disease becomes less disruptive as people learn to cope with it. And sometimes people can live independently, but it's good to keep track of them just because you never know when they might need a medication change or update. Some of the other disorders associated with it, schizophreniform, which is kind of like a mood disorder plus schizophrenia, but it's manifested in basically the hard symptoms. Catatonia with waxy flexation, that is, as you put them in a position and they stay there. They don't talk, they have mutism, or if they do talk, it's very, 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 very slow. Delusional disorder, they believe they're Jesus Christ. A brief psychotic disorder, this can be induced by medications, or it can be just something that happens because electrolytes are out of whack. But it does manifest itself as psychotic. A shared psychotic disorder, that is hysteria, where a number of people believe a certain thing, like it's the end of it's that what was that, Jonestown, where people drank the Kool-Aid and killed themselves because they all believed it was the end of time. That's a shared psychotic disorder. And then schizotypical personality disorder is not really schizophrenia, but it looks like schizophrenia, but it's more personality. We'll talk about that one later. There is genetic linkages in it. Less brain tissue, cerebral spinal fluid is thicker. Dopamine excess or dopamine less. There's less dopamine, too much or too little. And serotonin modulation dopamine. So some people think after flu, some people can get this. Some people think pregnant women can get this because of exposure to respiratory problems like COVID. Their kids can get it. It's genetic. There's a genetic code, there's genetic link. So positive symptoms of schizophrenia including flat affect and social withdrawal. They sound like negatives to me. Culturally, they have to be very cognizant of culture of what some people consider delusional and what cultures others accept as true. There is a whole culture of people around here who are atheists. They don't believe that there is an afterlife. They think we're all delusional for believing that. Some people, they say they have visual hallucinations, auditory hallucinations. It's all part of the entire, I think it's Santa Maria, that whole entire religious culture. They actually have the spirits that talk to them. And then there are some concepts or idioms of distress, how people experience that. It's not pathologic, it's just how your culture expresses the schizophrenia. Then we got to remember that there are ethnic differences in response to the psychotropic medications. I'm not going to speak to that because they're very microscopic. So the different ones, the ones that treat the positive symptoms, are conventional antipsychotics. That's your Thorazine. It's been around a long time. It only treats hallucinations, delusions. It does not treat the others. Then we have atypicals, dopamine, serotonin antagonists. They work on both. So that's more of the second generation antipsychotics. So that's more Seroquel, um, Clozaril, those guys. And again, if I want you to know it, I'll tell you. There are 6 antipsychotics in long-term. Um, Haldol and Decanate, that's not a good one. People use Haldol at the nursing homes, and the bad thing about it is it has a long half-life. And when you put it in Decanate, it extends that half-life of almost double. And this is the one we're giving to little old people who have decreased kidney function. So you give them an injection, should be gone in 24 hours. It doubles to 48, and somebody's creatinine clearance is maybe 1.3. And so it has a very sedating effect if it works at all. Then we have fluphenazine and decanate, and ethylate preparations, risperidone, paliperidone, olanzapine, aripiprazole. All of those are longer acting, and they can be given as injection. And it can take a long time for oral therapy, so you may see them, if you're transitioning from injection to oral, you may see them on both for a while, with the injectable becoming less and the oral becoming higher dosing. We see that in Coumadin and heparin all the time. So it's just something that they can do. There's something called extrapyramidal side effects that come from your classic neuroleptics or antipsychotics. You have more EPS with your first generation or conventional antipsychotics than you do with your second generation, which is good. There are 4 of them. They are acute dystonia, akathisia, Parkinsonianism, and tardive dyskinesia. Tardive dyskinesia, sometimes they set it separately than the EPS because it is irreversible. So if they get that, that's not going to go away. The others usually can reverse with decreasing the amount of the psychotic drug or stopping it altogether, or treating it with Artane, Benadryl, or Cogentin. Some other things that can happen because of these drugs, they can have seizures. It lowers the seizure threshold. And it can also cause neuroleptic malignant syndrome, which is like a temperature of 105, 106. It's very deadly. These neuroleptics are. Other side effects, weight gain. That's a big one for Zyprexa. Zyprexa is a second generation antipsychotic. It causes metabolic syndrome because it causes weight gain. We have sedation, increased sedation. You do see that in Seroquel. We give that one at nighttime because it makes people tired, or Trazodone. Those are both second generation antipsychotics. Photosensitivity, so sensitive to bright light, things like that. Burns, yeah, you can burn when you get outside. It's another photosensitive reaction. So all of these need to be, the education with these. You take this at night, don't take it in the morning. Watch your diet and exercise. If you go out, wear sunscreen and sunglasses. And then, of course, with all your neuroleptics is the anticholinergic symptoms. And you guys have probably heard these forever, so I'm not going to belabor them. Therapies, definitely one-on-one to begin. Once you got the psychotic symptoms under control with schizophrenia, then you can put them in groups. They need to train to ignore the symptoms that they're hearing, if they're hearing voices. Cognitive adaptation training or enhancement therapy basically are ways to train your brain to reject what is not real. And you do have to treat the family. There's something called in NAMI. NAMI is the National Alliance of Mental Illness. There's something in there called Family to Family, which is a specialized program for family members of those who have schizophrenia. And if you go to one of the support groups, or if you're interested in that, they have a few through St. Rita's. Family to Family is much more about educating the family on how to recognize recurrence or recognize the need for a change in medication. Which is a neurologic side effect of antipsychotic therapy. Neurologic. Maybe sedation? Oh, tardive dyskinesia. It's neurologic. Blurred vision, sedation, anesthesia are non-neurologic. Okay, that's kind of unusual, but that's what it says. All right, so assessing someone with schizophrenia, we want to assess their history. When did it first start? Oftentimes, like I said, they're going to be in a complete psychotic break, so you might be getting this information from a family member um, until they can get under control. Then you can do a better history with them. You want to know their support systems, their perception. Look at their motor behaviors and speech, which may be a little odd. It could be very slow, which is that catatonia. They could be using word salad, which is just individual words that don't mean anything. They could be using echolalia. They could be using palilalia, where they pretty much like, oh, no, no, no. That's palilalia. Echolalia is where they mimic the behaviors of the people around them, the language of the people around them. And the slowness of response. Look at their mood and their affect. Are they flat? Because they could be. Look at their anhedonistic. So are they passionate about anything? Look at their thought processes. Do they block thoughts, which is basically they're talking a mile a minute and then their thoughts just stop. Thought broadcasting, they can like tell you what they want you to think. People are taking thoughts out of their head. That's with thought withdrawal. They're putting thoughts into their head. That's thought insertion. They believe all these things. So we need to be able to describe them. Delusions, fixed false beliefs. Okay. I'm going to look at their sensorium, their intellectual processes. The hallucinations attach themselves to your symptom or your senses. So taste, touch, hearing, smelling, all of those can have hallucinations attached to them. They can depersonalize. So they're watching themselves. You want to look at their judgment and insight. They cannot make a decision very effectively. Their concept, self-concept, they don't even know who they are, let alone what they're about. So roles and relationships, a lot of times families don't want to be a part of this person's life. So you may see some very strange relationships, strained, or if at all. And then self-care. So they usually, you're going to see a lot of people who haven't bathed, a lot of people who've not taken care of themselves. To recognize sensations such as having to go to the bathroom, they don't recognize that sensation. Or thirst, they don't recognize when they're not thirsty anymore and they continue to drink something just because it's an automatically doing it. Data analysis, they're dangerous. They could be dangerous to themselves. Lots of times they're not dangerous to others, but there's always the potential. So you have to, because of their thinking, so you just have to be on guard. Focus on safety. That's a big one for everybody. Keep them in contact with reality. If you have to use presentation doubt, that seems really strange that would be happening right now. Like I had a guy, he was 25, 26, something like that. And he was rewarded every week by going golfing with the Pope because he killed Hitler. And he actually had a fleet of ships and he had a fleet of aircraft that were gifted to him by the president because he was very influential in making the decisions regarding some treaty he made up in his head. But anyway, so I told him, I said, you're 25. It seems rather unusual that you would have been alive when Hitler died, because he died in 1945. So I think there's about 30 years there. That's interjecting doubt. And that's a therapeutic technique if you use a lot with people in schizophrenia. So don't feel bad to use that. But again, safety, contact with reality. If somebody says they're hearing things, you can say, I believe you're hearing them, but I'm not. So keep them in touch with reality. Actions, safety. Trust with that therapeutic relationship in those communications. If they have delusional thoughts, don't argue with them. Those delusions are fixed and false. You can distract, you can change the subject, you can do other things, but if he's Jesus Christ and he believes he's Jesus Christ, you're not going to change his mind. So don't argue with him. That is not benefiting everybody. Teach them socially appropriate behaviors. It is inappropriate to sit out in the common day room without your clothing on. So you tell them, say, we need to move to put some clothes on. This is not appropriate behavior. Take them back to the room, help them get dressed. Lots of education for relapse. I talked about that. Self-care, nutrition. So make sure they eat and drink, but not to excess. Families need to help with medication management. Oftentimes they can achieve, self-medication, but it takes a little while. So the nurse should confront the client's delusions. No, you will never win. Age-related children, usually, I think there's one on TikTok or something. They say she's a schizophrenic and she's like 5 or 6, but I don't know if that's real or not. It's on TikTok. So usually it happens in late teens, early 20s, younger in men and women. Late onset can happen after 45, but that is not common at all. If it's something that delusions, hallucinations, it's usually associated with Alzheimer's or dementias or something along those lines, and not necessarily schizophrenia. Older adults. All right, we're not going to talk about older adults until we get there. Community-based, there's a lot of different group homes people can move into, a sort of community treatment programs, support programs. It's going to take a lot of case management to get all that set up, and they do have that at most institutions. Your goals for rehab, if you have someone who is aware that their reality is different than your reality, is being able to learn how to make their own life choices and treatment decisions to improve their quality. We can help them with self-efficacy and empowering client, resiliency and coping, but the key is they have to realize that they do not, at the time they're diagnosed, they have a different reality and they always have the potential to slide back into that different reality. They need to know that. And if they can accept that and they can see the warning signs of that, then all of this can come to fruition. But if they can't, and this is my case, I see a lot of this, they just don't have what's called insight. It's going to be a struggle for their whole life. And then you have to realize how comfortable you are dealing with people who have odd behaviors or unusual behaviors or and how you deal with it. It can be scary. If it's not for you, then don't do it. Schizophrenics are my favorite patients just because their reality sometimes is so much more beautiful than the way it really is for the rest of us. So not that you feed into it, but you can listen to them talk about it and you can see the comfort it brings them and how you can help them cross into our reality, the real reality. It's weird to say, the real reality. And have the same kind of comfort. It can be difficult, but they can do it. They can get better. It's possible. All right. So there's everything. So I hope the quizzing helped today. I hope this little extra time helped today. And I'm going to post this up so you guys can watch and we will go from there. Okay. I will talk to you next Tuesday, the 1st, and it is the 1st, just so you know, Javier.